All right, so welcome everyone to the February Health Equity Workgroup Meeting. Happy to see everyone. Hope everyone is staying warm. I know I hear that wind outside, and I am just mad at that groundhog Phil for declaring 6 more weeks of this. So hope everyone is having a good week. And again, thank you so much for joining us for today's presentation. So I know I see a few new names on with us today. So if you would like to introduce yourself, come off of mute and introduce yourself with your name, your organization. And we know a lot's going on in the world right now. So just want to check in with you individually. We're asking everyone, how are you doing today? I see Mr. Taylor, you got the thumbs up. Everything going well over there at Vibrant Health and Wellness? Wonderful. Well, I can get us started. For those who I've not met yet, my name is Taylor Palmer, and I help manage our local health improvement coalition here in Prince George's County. And so that includes the Health Equity Workgroup that you're all here a part of today. And we also have a behavioral health workgroup, a community care coordination team, and a healthy eating, active living workgroup. So if anyone is interested in those meetings after today, please do feel free to email me. I'll put my contact information in the chat.
Right now, do you require consent?
Does anyone want to do an introduction?
Sure, I can. Hi, my name is Christina Williams. I'm from the Rodham Institute at Georgetown University. Can you guys hear me?
Yes, we can.
Awesome. And how am I doing today? I'm doing okay. Surviving day by day, but just trying to stay positive. So yeah, thanks for asking.
Thanks for joining, Christina.
Thank you for having me.
Anyone else want to introduce themselves?
Hi, I'm Greg Taylor, the founder and president of the Vibrant Health and Wellness Foundation. How am I doing today? As Steve, what was the guy's name? Steve, not Harvey, but he talked about swimming with the sharks without being eaten. So that sums it up for me.
Thank you, Mr. Taylor. Good to see you today.
Yeah.
All right. Anyone else?
Hi, I'm Barbara Butler Killingsworth. I represent the Prince George's County Public School System as a nurse manager.
Hi, Barbara. Good to see you today. All right, well, we will go ahead and get into our agenda, but feel free to continue using that chat function. And as always, if you want to exchange any contact information, feel free to put that in the chat as well. So for our agenda today, we have a very exciting presentation from our partners over at La Clinica del Pueblo. Really excited to hear about their needs assessment and some of the policy recommendations that they worked hard to achieve recently. And then we will open it up for open discussion. As you all know, in our last meeting, we had a very candid meeting about where folks are at in this changing public health ecosystem. And so we want to make sure that we're continuing to have those conversations with you all, continuing to check in, hear about any troubles that you may be having, any hurdles, and see how we can best support you all as a work group and as a health department as well. So please stick after Rodrigo's presentation today to talk a little bit more about your organization and to see how we can all come together during these times and best support one another. As usual, we will wrap up with our community announcements and we will adjourn for the afternoon. So with that, for those who are new and joining us today, we always like to kick off our meetings under this shared vision with Prince George's County as a place where everyone has equitable access to achieve their full health and wellness potential, regardless of race, color, religion, country of origin, immigration status, class, age, disability, sexual orientation, gender identity, or health literacy skills. And so we thank you all today for joining us to work towards this vision. And so with that being said, it is my honor and privilege to introduce our partner presentation today, La Clinica del Pueblo, a wonderful federally qualified health center here in Prince George's County, also with services in the District of Columbia. I'm going to pass it over here in a minute to Rodrigo Stein, who is the Director of Health Equity and Strategic Partnerships. Several of Rodrigo's partners have been with us on these calls and have been a valuable partnership. So really thankful to have their partnership in their presentation today. So Rodrigo, I will go ahead and pass it over to you and your team.
Thank you so much, Taylor. I'm just trying to get the right. There we go. Everyone can see the screen.
Yes, we can see your
Yes.
first slide.
Perfect. Thank you so much. So thank you so much for providing us the space to talk about our, we call the participatory rapid appraisal. I'll go into a bit more detail of how we conducted it, why we conducted it, some of the outcomes. But to begin with, I think it's important to introduce, I guess, myself as your speaker, who's taking a bit of your time this afternoon. So my name, as I said before, my name is Rodrigo Stein, Director of Health Equity and Strategic Partnerships here at La Clinica del Pueblo. My story is born in El Salvador during the civil war years in the 1980s to a Honduran mother and Guatemalan father. So if Central America could be or remain the country as it once was, I would probably identify as a Central American. Due to my father's job, I moved a lot when I was a young kid, and sort of continued that trend into adulthood as well. So I've lived in over 10 countries. However, none of those have been due to dislocation or forced migration, which is a shared, which is the story of a lot of our community members and most of those who receive services here at La Clinica del Pueblo. So also before working here at La Clinica, I had a lot of experience in sports-based youth development, which was sort of my opening into public health, and how I arrived at understanding what I had been doing for years was actually public health. And now I'm fully involved in everything related to public health. And as I said before, I've had the opportunity to receive education in Canada, UK, and the US. So that's a bit about me. So what are the objectives of our presentation today? So provide a bit of an overview of the Latino population living in Prince George's County, the health barriers they face, also emphasize the role of FQHCs in promoting health within the county. And I guess the most important, or like why, is highlight La Clinica's participatory rapid appraisal approach as a form of community-based participatory research that can complement efforts done at the local health departments and other organizations in understanding perceptions of health conditions, barriers, and collective solutions to overcome them. Before I begin with the presentation, any questions? I'd like to make sure. Please, as I go through the presentation, please interrupt me if I'm going too fast. And also at any moment, if you have any questions, I don't know, Taylor or Abril, my colleague from La Clinica, is here as well. If there's any questions in the chat, just please let me know. Perfect. Uy, what happened? There should be an image there. Yeah, can I stop sharing? Because there should be an image. I don't know why. Anyway.
I was seeing images. I see a
See
map.
the image? It should be a map of Central America.
Yes.
We see it.
You see it? I don't know. It doesn't show up for me, but if you all see it, that's what matters. So, when we talk about Latinos, I know we're talking about an expansive region of the world, 24 countries, each with its own idiosyncrasies, histories, and relationships to the US. So I think it's important and also the term Latino. What does Latino mean? Who is Latino? Who would belong to Latino? I think that is not the purpose of this conversation. It is a very interesting conversation, but we want to narrow the scope of the conversation for our purposes. So in the region, there's over 900,000 Latinos, Latinos being, as I'm using Latino, and all of those who were born or have direct lineage to someone from Latin America. Latin America being an expansive region from Rio Grande to Tierra del Fuego, 24 countries, a lot of Caribbean islands as well. So that is a very expansive region. However, who are the Latino immigrants in our region? And those are primarily immigrants who are coming from Central America, primarily El Salvador, Honduras, and Guatemala. And they represent the largest Latino immigrant concentration, the largest Latino immigrant in the region. And just behind New York and LA, they are the third largest concentration of Central American immigrants in the country. So the reasons why people migrate, I'm not going to narrow it to one only. There are multiple reasons: family reunification, economic improvement, displacement. There are a number of reasons why people migrate and relocate. However, there is a history that can be told specifically for Central American migration, and and it can be really tied to events happening from the 1980s onward. So as some of you may know, during the 1980s and prior to the 80s, there were movements all across the world, not only in Central America, but also for self-determination, recognition, land redistribution, wealth redistribution. And as such, the United States had a firm policy of containing communism that led to counter insurgencies or counter movements for the revolutions that were happening across the region. This essentially resulted in civil wars happening and breaking out in Honduras, and Guatemala, El Salvador, Nicaragua as well, and Honduras being sort of the hub where the counterinsurgency was being deployed across Central America. This generational trauma, which also happens before, is deeply tied with the migration flows, as during the Civil War years, the flows of people coming to the United States were not necessarily afforded the same asylum status that people fleeing the communist regimes from Cuba, for example, even from Nicaragua, were being afforded the same asylum status as the people fleeing primarily Honduras, from fleeing El Salvador and Guatemala, were fleeing from friendly territories according to the United States. This resulted in a lot of these populations not being granted the same asylum status or access a transition to an immigration status that could be then be recognized. Also, it's important to note that despite the increased rhetoric that we're hearing right now from the Trump administration, that nativism and xenophobia that has been ramped up right now is not new. It has been a consistent policy for years. For example, the IRCA Act signed by President Clinton in 1996, which included the 287G clause, conflated what is an administrative procedure, which is adjusting an immigration status, with a criminal status of crossing the border illegally or being out of status as a criminal act instead of an administrative requirement. Also, We have to remember that President Obama deported 3 million people during his administration. So, and if we even go farther back, nativism, xenophobia have been pretty consistent across the history of this country, with right now being ramped up. So I just think it's important to ground ourselves in the history, who we're talking about, and the reasons migration happens. Any questions so far? Perfect. So what is the health status, access to healthcare barriers of some of these populations? So it's important, if we focus on PG County's population, we know that about 24% of the county's residents identify as Latino. As I said before, most of these being Central American origin. They represent the second largest demographic next to the Black African American community. And there are majority in areas like Adelphi, Brentwood, Riverdale, and Langley Park. So what are the risk factors that we see among this community? High blood pressure, obesity, all risk factors closely tied with chronic conditions, but also in other areas such as mental health, number of average days of reporting poor mental health. We also see high prevalence among the Latino community. Additionally, for the health status of the community, we also understand within the immigrant community that like 8% of the United States, which is limited English proficient, PG counties is 7%, so very similar. However, in those distinct zip codes like Adelphi, like Langley Park, which I just mentioned before, we have areas in the county that have 3 times the average of limited English proficiency. So adding an additional barrier. From the experience that we know as a culturally sensitive healthcare provider, and the experience or the fundamental need of having culturally and linguistically accessible service, the importance of having not necessarily consistent access to bilingual professionals, but at least highly trained medical interpreters is key to promote good outcomes. Furthermore, we know that variations based on health insurance, based on our immigration status, ultimately determine a lot of who gets access. We're fortunate to be in a jurisdiction like the District of Columbia, which offers the DC Alliance, which is a local health insurance program for those excluded from Medicaid. Also, we've done expanded some victories in the county and in the state through the Healthy Babies Equity Act and the Access to Care Act. Still fighting for the PG Cares Act and Health Assures at a county level. But it's important to ground ourselves that the immigration status of a lot of individuals, even those lawfully present and with recognized immigration statuses, are restricted from certain access to Medicaid, particularly. For example, TPS holders are not eligible for Medicaid as their status is renewed every year. They are available for ACA subsidies and plans, but not Medicaid. In addition, the types of jobs, the income and occupation that a lot of our community is engaged in restricts or forces people to make difficult trade-offs, even when employee-sponsored healthcare is offered. So the wages are so low, rents are so high, and the cost of living is so high, plus remittances that must be sent over back to our countries of origin, put people in difficult trade-offs where maybe healthcare is not the priority. So even when it's offered at an employer level. Questions so far? Perfect.
Yeah, I have a question. This is Greg Taylor again. So you talk about the population of Prince George's County is roughly 225,000 Latinos. And out of that, you said 24% are uninsured. And so how are they getting care?
So there's a range of options, including the services that we provide at an FQHC. A lot of it is uncompensated care from emergency rooms as well, but FQHCs, we have a mandate to promote healthcare to all, regardless of their ability to pay.
So you are addressing that 24% of uninsured. You have a way to address that, to mitigate it.
I wouldn't say we are addressing it for all, and that's why we need expansive solutions and county solutions as well, and that is the reason. But for example, through the Healthy Babies Equity Act, pregnant women and their infants up to four months postpartum are able to receive prenatal and postpartum care. Right now, with the Access to Care Act taken into effect, I believe in 2026, they will be able, all persons, regardless of immigration status, will be eligible to participate in the market exchange to purchase health insurance. And those are the mitigating factors and the services that we as FQHCs provide step in to cover. So, but that's a good question, yeah. And I think that's from the state, that's not only PG County.
Okay, so when you say that 24% is from the state.
The state of Maryland is.
Okay, I got you. I was thinking that 24% of the 225,000 Latinos that reside in Prince George's County, and out of that, 24% are uninsured. But okay, I see it now. It's Maryland. Okay, thank you, sir.
Perfect. No, you're welcome. So just to sum up, immigration stressors and low income combine and just act as reinforcing or enforcing determinants of health. Both federal and state eligibility policies disproportionately exclude immigrants with varying immigration statuses from safety net services. This is not only a documented versus undocumented issue. People with documented and legal statuses are also excluded from a number of safety net services. Then once again, the financial constraints. A lot of the population works in many low-wage jobs without employee-sponsored insurance or must prioritize basic needs. And as I said before, with the language access, there is a routine experience of discrimination, whether interpretation is not provided, even though that's a requirement under Title VI. There's a number of stories where the encounter with the safety net systems and healthcare is not culturally and linguistically responsive. So what is the role of an FQHC like us? We're federally mandated to provide comprehensive primary, oral, and mental health substance use care to all of individuals, regardless of their ability to pay. We're a critical part of the healthcare safety net, serving over. Sorry, I saw a comment from. Sorry, I see a comment. I don't know if. I think from Sharon. Sharon, please jump in.
Oh, I just wanted to clarify that undocumented and people with previously excluded immigration statuses can now purchase on the marketplace, but they are not eligible for subsidies, which means that they're paying full freight for the cost of insurance, which is really prohibitive to many people who might seek to purchase care.
Yeah, absolutely. Thank you so much, Sharon. And sort of building on what Sharon was saying, so safety net providers like La Clinica, which and other FQHC partners, we do have some capacity and reimbursement limitations for specifically uncompensated care. For example, for us, hiring and training, identifying fully bilingual healthcare providers, So even though we do exist, we're still operational, we struggle to meet the high demand of such a population in need. So the history of La Clínica itself, it started, as I said before, you can trace the history of the organization with sort of my first slide. Starts in the 1980s with the first influx of Central American refugees fleeing the armed conflicts in Central America. It starts out as a program here in the District of Columbia as part of Carecen, which I know a lot of you maybe have heard of. The organization grows to an extent where it is able to become a standalone program in the 90s, becomes a 501c3, and since 2007 receives the designation of FQHC. And we've been operating in Maryland as an FQHC since 2016. So our model is truly to provide an integrated approach, prioritizing both primary care, mental health services, with the added wraparound services provided through our community health action, health equity, and language access units, which community health action promotes not only public health campaigns and health education strategies, but also is our strategy to be grounded in the community through community health workers. And our health equity and community partnerships works around mapping barriers, sort of what I'm going to present in a bit. Also addressing some of the policy and advocacy, and also the deployment of medical interpreters across the region. So we see over 4,000 people, 3,000 of those are Maryland residents. So the majority of people that we serve are Maryland residents. Some of them receive services in DC, but most of them reside in Maryland. And these are our sites. I have a primary care site in 15th Street here in the District of Columbia. Our Prince George's County site is in I was going to say PG Plaza Metro, but I think it changed right now, right? I can't remember what's the new Hyattsville crossing. They changed it. The Green Line. They changed. Anyway, the name, the PG Plaza Metro, now with a new metro station name. I can't remember it right now, but that's where we are located. And we have 3 based school mental health providers, Mi Refugio, but I'm just showcasing our flagship, which was opened in Northwestern High School. So I'll proceed now to explain sort of like our project on, around understanding the perceptions of health conditions and primary barriers using a rapid appraisal. So what is a rapid appraisal? First of all, it's a form of community-based participatory research, which essentially has core elements such as collaboration, active community involvement, not only by soliciting the community's health priorities, but the community itself develops or recommends the interventions necessary. It is essential that its methods and strategies equalize the power dynamics instead of a facilitator extracting information. The group co-creates the information, and there is an element of even handing over power. For example, as facilitators, we don't write responses on behalf of patients. We don't even tally on behalf of patients. We let the flow really be devolved back to the community and empower them. And I'll explain what I mean before. The method that we used has been applied across disciplines and the social, I was going to say social science, yeah, social sciences, but also across interventions in housing, with a lot of resource poor communities to address issues such as climate change, urban violence, informal economy. And it is not unique to public health per se. and it can be adapted across disciplines. It's important that the approach really is set in being purposeful in segmenting a number of affinity groups that have shared characteristics, and then tally those totals to get a real understanding of what is going on in the community. So what we tried to, with those principles in mind, we set out to understand what were the most common health conditions that the community was perceiving affecting Latino immigrants in the District of Columbia, Maryland, and Virginia, and what were the significant social barriers that were preventing that community from improving or enjoying better health. So what is the process that we followed? La Clínica benefits, as I said before, from a health education, its community health action department and other strategies that, as part of their core components, it is to convene groups across shared health conditions, whether that's chronic conditions, living with HIV, etc., and promote lifestyle or behavior change groups. So we're able to recruit among those different affinity groups that belong to people living with certain health conditions, or even being part of our health promotion or promotores de salud group. And we're able to recruit based on those affinities, which gave us a good representation on age, living with certain gender, living with certain health conditions, and jurisdictionally as well. So we hosted 7 community conversations. All the conversations use the same data collection tools and ask the same questions. And since all groups use the same questions and data collections, you're able to create clusters to interpret the data through content analysis and then quantify totals. So the method that we use to collect what was the most common health conditions and barriers is our listing and ranking method, which is really a manual process, as you can see from the photo right there, of community members listing what are the health conditions that they're experiencing, and then assigning 3 votes, 3 being the most pressing, 2 the second most pressing, and 1 the third less pressing. And then we would follow through what we call a causal flow diagram, which allowed people to dissect what is the cause of that major health problem, and then do the listing and ranking process again. And once that process was completed, we were able to triangulate results with other sources to understand what we were finding is being identified across the literature, and if we were missing anything. I won't go into too much of detail in that, but yeah, the content analysis is done through we were able to synthesize what we were finding by matching the health clusters with the WHO social determinants of health framework and their mortality database to match what we were seeing and cluster it around those conditions. So what were the results and outcomes? From the participants, the majority were female. The age groups that were most represented were all working adults. We did have a group of, as I said before, in our school-based program, which is represented by 15 to 21-year-olds, but the majority of people were of working age, or working adults, female working adults. No surprise, their countries of origin, as I said before, the PRA just validated that the majority of people in our region are from Central America, from El Salvador, Guatemala, Honduras. I know we're seeing a higher amount of Venezuelan immigrants. However, the majority still are Central American. In terms of the zip codes most represented, we had 2781, 2782, and 2783 as the most common PG zip codes represented. And what were the key findings? Well, the community perceived mental health to be the major health concern affecting their community, followed by chronic diseases and then substance use, and the barriers that prohibited the community or the community perceived did not allow them to enjoy better health or improve their mental health or chronic conditions were tied to income and occupation, access to health services, immigration status, access to food, and language barriers. These are just some quotes to highlight what the community was telling us or what participants were saying, tying discrimination, tying discrimination to depression, right? Like the experience of discrimination was a barrier that did not allow people to improve from feelings of depression. Also, immediately acknowledging that poor diet is not necessarily bad choices, but a problem related to heavy work schedules and precarious work. There's also an acknowledgement and recognition from the community that it's not necessarily the lack of jobs or lack of opportunities, is those jobs are exploitative and don't pay what the cost of living demands or the situation requires to be earning. And also an immediate recognition around the neighborhood and conditions that surround their communities. Overly exposed to fast food environments, and also acknowledging the income disparities between who can afford to live where, who can afford to shop places. So there's an immediate recognition of what we would call the social determinants of health. I want to make sure I'm not missing anything, if there's any questions.
No, we're just working through some tech issues, but no questions in the chat yet.
All right, perfect. So once we started comparing what we found with secondary sources, so for example, we compared what we found in our needs assessment with, for example, the most recent 2023 Montgomery County's Community Health Needs Assessment, and also the 2022 PG Needs Assessment, and they were very similar. For example, mental health, obesity, and diabetes were the top concerns among Latino respondents in the Montgomery County's Community Health Needs Assessment. In Prince George's County, through the health needs assessment done here, mental illness and obviously I believe COVID was the first one in that year, but also mental illness and substance abuse were ranked second, third, and fourth most common conditions as reported by the Prince George's County survey, and it sort of resembles what we found ourselves in our rapid appraisal, with the community identifying mental health, chronic conditions, and substance use as the most pressing health conditions affecting the community. Once we started triangulating a bit better with like additional sources, once again, the rapid appraisal told us that the community identified income and occupation as the #1 barrier. And once we identified other sources tracking the community, we see the income disparities affecting Central American immigrants. So I believe the most recent, and I might be wrong because there's so many household income figures from different sources, but the most recent PG median household income, I believe, is 125 or 101. I don't know. I would love anyone to correct me on that one. But once you trace it down, you do the household income according to the Migration Policy Institute. it is 70,000, the median household income. Once you do the aggregated even further among Central Americans is 55,000. And the community health needs assessment, for example, in the resident survey, identified that all the Spanish-speaking participants who participated in the community needs assessment of PG County reported an income of 49,999. So there's a vast income disparity, and that demographic of Spanish-speaking residents, I complemented with such a high percentage of women participating in a rapid appraisal. And as indicated, once again, from data from the 2022 health needs assessment from PG County, which reports the highest poverty rate of them all, sort of validates income and occupation as why it's the #1 barrier for a community, and also was validated by the high participation of women in our needs assessment. So as you can see from a very participatory approach, very community-led participatory approach, our figures resemble a lot what local health departments are showing, but with the added value of more participation from the communities that sometimes may not feel that may feel intimidated by participating with local health departments and other agencies. Once again, if you compare what we found in a rapid appraisal with access to food as being a significant barrier, and you compare it to the U.S. American Communities, the U.S. Census American Community Survey, there is food insecurity at 8% for all Latino households, and we found that 11% identified food access as a tremendous barrier. So there's a similar figure that we found and what the U.S. Census found. So, any questions? And I want to make sure I still have enough time.
Yeah, we are all good time-wise. Does
Okay.
anyone want to unmute and ask any questions or any reactions to the data that Rodrigo just presented?
Good afternoon, everyone. I apologize for my tardiness, but I'm not at all surprised by the data that you're sharing with us. As a matter of fact, what we have been experiencing here at the Black Mental Health Alliance in regards to the calls that we're getting for assistance, it bears out exactly what you're reporting. I want to thank you for this. I'm so glad that I've even been able to get a part of this afternoon because this is very good information.
Thank you so much. So, and as I said before, the method that we're using does not stop at identifying barriers and identifying conditions, but it takes it a step further, and it works together with the community to generate concrete recommendations on how to move forward. We also know that it's also specifically in this environment, it's not up to, we can't really expect the communities to, how do you call it? There's an element of safety, right? Right now, an element of safety has to be taken into account. So we work in coalition, working to advance these policy recommendations. And I'll show you the sort of the process of how we took it to working with a cross-sectoral lens to advance what we call health in all policies in the public health world, because these are ultimately socially determined and not necessarily an issue with the health system, but also the living conditions that surround us that need adjusting. So sort of the process that we followed, as I said before, we the first, that is a short timeline of the process that we followed. From July to October, we did our community-based conversations, analyzed the data from October to March, from 2023 to March 2024. And once the data was clear to feedback to the community, we re-invited them to present what they had told us, what we had worked together to identify, and sort of like the data that I just presented to you all, and also generate some recommendations of where we could work together. Those recommendations were then further validated in another setting where we invited cross-sector partners in August to finalize sort of the recommendations. So the first process was identifying the problems, which happened in 2023. The second step was, with the same community, generate policy recommendations. And the third process was validate those policy recommendations exclusively, not only with exclusively with cross-sector partners, but also public agencies from the District of Columbia. This is our first Prince George's, but so far with DC, we shared the data. So what were some of the recommendations? I tried to be specific to PG County right now, because the policy recommendations would have not necessarily applied to it would be for the District of Columbia. But for example, right now, we know that there was policies to ensure fair wages by increasing the minimum wage. That would be incredibly helpful. I think it passed and will take effect right now in July 2025. But also, if there's opportunities to increase workplace rights protections or grants that familiarize employers with or employees with their own rights, that is something that was also recommended here in the district. Another policy recommendation that was generated from these conversations was the idea to establish programs like the Montgomery County's Welcome Back Center. I believe the Prince George's County nor the District of Columbia has something similar. If any of you all know of something similar, please let us know. But it's essentially a navigation center that allows internationally trained professionals in the health education fields to orient them how they can validate their credentials, and also, and at the same time, reintegrate themselves into the workforce with their in their field, and also increasing the culturally competent workforce that is more and more needed, but also address some of the language barriers. The access to healthcare that was proposed in the district was parity between DC Alliance and Medicaid. However, here we know that protect Medicaid access, specifically for the Healthy Babies Equity Act, is key. Also, identifying a local reimbursement mechanism through our PG Cares program, and also protecting the health assurance program at the county level are key, but also make sure that once the Access to Care Act becomes fully operational, that even though there are no subsidies, that we try to navigate people for insurance. And right now, we know that at a state level, Maryland House Bill 1473 ensures equal access or language access to public services for individuals with limited English proficiency and individuals with disabilities. So all that to say that, and to conclude, and those policy recommendations are live, and I would love to hear if any of you all know of any policy recommendations that we should be putting out or tracking that address some of the barriers that our community identified, from income and occupation, access to health services, language access, access to food, etc., to let us know and invite us to any of your coalitions. We would love to be a part of that. So just to conclude, the rapid appraisal and using the methodologies grounded in community-based participatory research and implemented by trusted organizations like us, like La Clinica, it complements the valuable data that local health departments are already collecting. Like the health departments are collecting wide range of data and big data, but we believe that the data that La Clinica can capture, or organizations like us, complements some of, or gives more life to some of that data that health needs assessments often miss. Internally, this data has allowed us to improve the type of cross-sector partnerships that we are trying to identify and strengthen, and also made it more visible across the whole service provision internally at La Clinica of the importance of health-related social needs. Once again, the data can also be used to confirm that immigration stressors are a determinant of health, and they indicate a need for comprehensive approaches that extend merely, and as a healthcare provider and as who have health access in the front of all their policy and advocacy strategies is not enough. Like, we need these comprehensive approaches that to improve the health of the community is beyond just health access. And also it demonstrates why the FQHCs were mandated to conduct needs assessments as well, but investing more than just a cursory approach of analyzing service utilization. Once it's that we should invest as organizations ourselves to really use some of these methods to understand what our community is needing. So, and that's my presentation. Thank you so much. I'm open to questions. And I don't know how to stop sharing. Sorry, I don't know how to stop sharing.
A red X. If you hover over the top.
Oh yeah, I saw it. Stop
there
presenting.
We go. Okay. Yes, you're just getting a lot of claps so far. And Deborah Collier, our senior epidemiologist here at the health department, she put here in the chat that she would love to have a more detailed conversation with you.
Perfect, thank you. I'll definitely look out for it.
Yeah, Rodriguez, this is Greg Taylor again. I was just wondering now, have you noticed the impact of the lack of grant funding, or has that slowed up? Is that your major source of income or resources to maintain your operations?
So the organization has a diversified approach to sustaining itself. As an FQHC, we receive a number of public grants to sustain, but we also have a wide range of services that are fee for service for based on the insurance. So in terms of a reduction, I think we're only in the second month of the year, so it's a bit too early to identify. Luckily, so far, with all the executive orders, etc., we have not seen, and we were just in a call yesterday within the National Association of Community Health Centers, which we're a member, also giving us an overview that so far, I know we're not, I guess, not even a full month, or is it a month today of this new administration, but so far we have not heard have been impacted as other organizations may have. So, but that's not to say that this is only month one. So I think it's too early to.
Good, thank you.
And I see Ninfa's hand.
Hi, Taylor. Thank you. Hi, everyone. My name is Ninfa Amador here with CASA. For you all that might not be aware of CASA, we also advocate for policies that increase health access for immigrant community, particularly undocumented individuals who, because of their immigration status, don't have access to healthcare. And I just wanted to make a quick note on something that Rodrigo mentioned. First of all, you all give a big round of applause to Rodrigo. That was amazing. And La Clinica is seriously doing beautiful work out here, along with all of our other FQHCs in the county, and ensuring that our most vulnerable communities are getting such needed healthcare. And on that note, at the state level currently, there are proposals of cuts to Medicaid, which would directly impact funding for Healthy Babies Equity Act, which Rodrigo mentioned. And as you know, like, we are going to have the Access to Care Act, which will allow individuals to buy health insurance, but as Sharon noted in the chat, that's unfunded, it's unsubsidized. So we are seeing lots of different ways that the immigrant community and the uninsured community is kind of being left out to an extent. So just wanted to uplift that possible threat of defunding for Medicaid, and then for the Healthy Babies program, a specific program under Medicaid. And then you all know that advocates at the state level are banding together to oppose any cuts to our programs that are lifelines for our communities. And if anyone is interested in learning more, I'm happy to leave some emails in the chat.
Thank you, Ninfa. Yes, would definitely appreciate that in the chat. And Ms. Cheryl, I see your hand.
Rodrigo, please put your information in the chat so that we can have access, especially an email address. And I'm going to play devil's advocate here. And I hope I'm not going to step on toes that I can't apologize for. But Rodrigo, we know that we are going to be challenged even more as this administration goes forward. What perhaps are organizations like yours doing in terms of the influx of people coming to the county that need so many of these services that are being stretched and going to be stretched even further as we go further into this administration? We know that everybody is saying the same thing. Don't cut my pot because my pot already isn't enough. Everyone's saying it. So we know what's going to happen. They're going to do what they're going to do. So how then are we, and I've had this conversation with a number of people, how then do we find creative ways to be able to have this pie that's already, the slices are too thin for each one of us? How can we creatively think out of the box so that we can use what we have? And we know it's not going to increase that much more because the writing's on the wall. How can we find ways to come up with being able to get those services to folks when that pie isn't, that piece of pie that we each have is not going to increase much, if it increases at all?
I wish I had a
I guess I'm asking that question because each one of us need to face, that's the writing on the wall, that's the reality. So if we're not getting what we're asking for, what's our fallback? We've got to develop a fallback because that's the reality of it.
I think, and this is I'm not going to speak on behalf of the organization. I'm going to speak on behalf of myself. But I do think that there's an element of, and I think tying back to what the data that we collected showed us, the universality of needs across material conditions, right? There are certain material conditions that we should not move an inch for. That includes access to care, that includes dignified wages and living conditions. And I think we as service providers have to develop that language and narrative that I guess moves beyond just our organization's bottom line, and like this is that is what the community ultimately and all of us deserve, and would need what actions can be taken. I wouldn't be. I think we have to. I wouldn't be able to answer how to translate that into action. I'd be open to hear from others what they have to say as well. But like I believe those material conditions that impact the dignity, safety, and livelihood of all of us are the ones that we shouldn't move an inch for. But yeah, I'm open to hearing what others have to say.
You know, for Cheryl, this is Greg Taylor again with the Vibrant Health and Wellness Foundation. We hosted a conference the 5th of April, Partnership for a Healthier Prince George's County. And this conference was planned prior to the new administration coming on board. But it's to address as Mr. Stern talked about, Steen talked about, some of it is political determinants of health, the social determinants of health, and the impact it has on our community. And we recognize now that, you know, not just the Latino community, in the case of you, Cheryl, looking at the Black mental health, you know, so you're going to be competing for those same resources. Yeah, you know, you have advocates say, well, you know, hey, why give it to them? I was born here, stuff like that. But the idea that we win when we unite. And so the conference is on April the 5th. Taylor have the flyer. I welcome everyone to participate because we want to have the business community step up, giving the residents a voice, as well as the local practitioners. And so the idea that I think, and here's a Greg Taylor's perspective, and I've been looking at this, is we got to go back to the basis of self-reliance, self-care, pooling our resources, and also promoting more emphasis on preventive care. And we all know that preventive care will reduce hospitalizations, the frequency of doctor's care, et cetera, et cetera. So I think that there's some things, and I always think about the book, Who Moved My Cheese? And the idea that now we got to become more reliant now. It's going to impact us to do that. And I don't want to say impact us, but insist that we take preventive means. And when we do this and we're hit with circumstances like we are in now, it requires a level of entrepreneurship, you know, to be more innovative and creative. And I think that we can accomplish that. So, you know, more to come on it. But if you find time to participate in the conference, I would welcome everybody to attend. But I think that's the way we got to start having these strategic alliance and stuff like that. And no longer can we depend on the governor. You know, his hands are tied.
We're tied.
The county's hands are tied. And so what can we do? We can continue to hear people just squawk about, well, the blame game, but the blame game is not moving the needle toward addressing these health equities that is so desired amongst our community.
Absolutely.
Yeah.
Thank you, Mr. Taylor. I will be sure to share that event information in our community announcements. Sharon, I see your hands raised.
Yes, I have a question for Rodrigo, a question for Nympha, and just a kind of a statement. I appreciated the comment. I'll make my statement first about self-reliance, and I think increasingly both state and local governments are going to be in a position to, I want to say, really look at how they're budgeting and distributing resources, because they're going to have to become a much more collaborative partner with the safety net, social service, and health agencies, because we don't know what's going to happen. We don't know how much money, federal money might not be there. And in the case of the immigrant communities, the money wasn't there to begin with. So, it's really ensuring that the money that's there stays there, that maybe there's a radical redefinition of budgets to look at how you preserve funding for um, for basic human needs as the rug gets pulled out from under folks. So that's just my statement. I think radical redefinition of budgeting and prioritizing what's important is ultimately the only way we're going to live through the next several years. Um, but the question I had for Rodrigo is very specifically, I remember during the last administration, there was a chilling effect based on people's fear of coming in for health services. And I know it's only been a little bit of time, but I was wondering if you've noticed that people are afraid to come in or bring their children in for healthcare. And can you tell us what we as a community can do to help people feel safe and enable them to access the services that they need?
Yeah, so that's a great question, and yes, we are seeing more demand for certain services to be remote. I think if there's anything that COVID taught us, we're good with that. We learned how to do it. But yeah, we've been hearing more stories of patients who don't want to come to appointments. Also, talking about the health-related social needs, people not wanting to go receive food assistance, all these other areas, in fear that. So it's a chilling effect, and it has repercussions not only at the health care delivery, but also across all the other social needs. In terms of what can be done, I would say promote, for example, we have a Know Your Right educational material. We'd be happy to share that with you all. You can share that. We're making emphasis on being not missing healthcare appointments, the importance of keeping your health, but also acknowledging to have a plan in place in case. So we'd be happy to share that material. I can share it with Taylor at the end of the call so she can distribute it. But yeah, I would say share that material, and where you can, as those pockets that have been carved out for the population who's been excluded from other access to care. Not if you can provide testimony, if you can provide on behalf of your organization, for example, the anticipated potential cuts to Medicaid, like protecting those things, I think go a long way. I would say those things.
Can I ask one last question of NYMFA, which is, I know there was, what's the status of the bill to protect safe places that were originally safe health centers, hospitals, schools, churches?
Yes, thanks, Sharon, for that question. So at the state level, CASA is pushing forth an immigration justice package that includes, it's 3 bills, and includes a bill on protecting sensitive locations. And in this call, healthcare facilities, clinics, any location where healthcare is being given. We had a bill hearing yesterday. If you all are not already plugged in, and would like to be plugged in and supporting us and getting this through, I'm actually gonna I haven't put my email in the chat, but I will do so. Please let me know. What support that we need is written testimony in support of these bills to the General Assembly, written emails to your legislators, even meetings with your reps and from the county, right, to let them know what you are seeing on the ground and why you need these protections. And this bill would ensure that there are guidelines to what ICE enforcement can be in sensitive locations, trying to limit any warrantless enforcement from ICE at these sensitive locations. And the goal, right, is to make sure that our community feels that they are cared for by the state, feels that they can confidently go seek healthcare without thinking about deportation or family separation that might come from that. So that's the goal for that one. And yes, please, if you all are interested in supporting us, we have a bill hearing next week as well. So yesterday we had a bill hearing in the House for one of our bills, but for the sensitive locations, we are going to be having a bill hearing on Thursday, the 27th. And if you can submit written testimony by Tuesday, the 25th before 6 p.m., I would be grateful for that. Taylor, I have a template that I can actually forward to you so that you can share with folks on here. And I have to drop, but if you have any other questions, please reach out to me. I'm leaving this email here and more info on the cuts as well.
Thank you.
Thank you, Nympha. I'll make sure that information goes out with the meeting notes. And really quick, I wanted to lift up a question that we had here in the chat for you, Rodrigo. Are you able to track how many, if any, of your survey respondents are age 60 and older?
Yeah, I believe we had that 60.
It was 60 and older.
Yeah. I think we had it in. Let me just remember. I'm just going through the presentation. Yeah, we had it by age. Bear with me.
Mm-hmm.
So I could tell that above 65 was 5 people, and then the breakdown I have to do a bit more detail, but we had 9 people between 55 and 65. So about, I would say 14. No, 9 plus 5 is 14. No, 9 plus 5 is 14, right? Yeah. So yeah, about 14 people, 60 and older, or 55 and above.
Amira, did you have anything else you wanted to add to that question?
No, I'm participating from the Office on Aging with the Department of Family Services. So we're interested to know whether or not these types of surveys are taking into account the needs of older adults in the query. So thank you.
Yep. That was a great question, and just to clarify, it wasn't a survey methodology. It was it's a group-based conversation, which actually all participants participated. So, but yeah, we had 14 people, 55 and above. I would have to get back to you how many are 60 and above, but at least
55 and above is a good measure. I asked for 60. But knowing that 14 people above 55, that's a nice healthy number for us to understand whether or not though their feedback is being taken into account. I was presumptive about the survey method. I joined late, but thank you for sharing with me that it was small groups.
Yeah, perfect.
And Marlene, I see you come off mute. Do you have a question you'd like to ask?
Yeah, thank you so much, Rodrigo, for your great presentation that you have today with us. And really, I bring my attention about when you say that in your recommendation to bring enforce the language access. Well, I'm part of the Horowitz Center for Health Literacy, and language access is part of the health literacy. And it's good to know. And also, I would like to everyone in your organization implement about health literacy, language, and language access. It's very important, not just for Latino community, but different other community is very essential, especially because it's part of the health equity. We need to start with that. And having said that, as a center, we have 2 events, 2 convenings now in March. One of them would be here in College Park, and the other is in Cambridge. And then I would like to invite you to consider to register, to have more knowledge about health literacy. And then I will drop off the link information here in the chat. Please consider to enroll and spread the word with other organizations that wants to implement health literacy, and that effort would be great for us and for our communities also. Thank you, Tyler, and thank you so much again, Rodrigo.
Thank you so much, Marlene, for the invitation there. I know I will be attending that first session in College Park, and I look forward to it.
Thank you.
We're going to go ahead and transition to our community announcements, but thank you again, Rodrigo, for being here today. And as always, we appreciate your partnership so very much and look forward to continuing these discussions. If folks have any additional questions, I know Rodrigo put his email in the chat. You can feel free to add your information in the chat, and I can help facilitate any connections and send that information to Rodrigo after we conclude today's meeting. So hopping back over to our meeting slides here, if folks are interested in continuing today's discussion, I know we didn't get into some of the individual level impacts that you all are seeing with your organizations on the ground. So do want to provide this opportunity for folks to continue to engage in this discussion. Next week, our community care coordination team is meeting on Thursday at 11 a.m. And we're going to be continuing and having some reactions to today's presentation and that report that Rodrigo shared with you all, some of those recommendations, and see some other folks to hear your feedback, and then to hear as a coalition, what can we work on implementing. So would encourage you all, if you are all available next Thursday at 11 a.m., please do feel free to join us. I can send the invite. If you can put your contact information, the best email to reach you at, I'll be able to forward that meeting invite to you all. And next, I want to go ahead and call up Lizzie to announce the Adolescent Sexual Health Project.
Thanks so much, Taylor, and thank you for welcoming me into this space. Rodrigo, your presentation was fantastic. Our main ask is to invite you all to support us in recruitment for focus group discussions on sex ed in Maryland. And I will put that in the chat quickly before I forget. But I work for an organization called Cardia. Melanie Ogleton connected us to your group. Melanie's a member of the Equity Workgroup. And Cardia is partnering with the Maryland Department of Health to assess adolescent sexual and reproductive health needs across the state, focusing on sex ed and youth-friendly services. So the aim of this project is to inform a statewide strategy and evidence-based programs tailored to Maryland's youth. So to gather insights, we're hosting virtual and in-person focus group discussions with young people aged 16 to 24 who have received sex ed in Maryland schools. Specifically, we're interested in working with existing youth groups. So far we've been talking to existing youth advisory boards, youth councils, and so on, and we've been joining their meetings or having a separate meeting time to host this conversation together. And we've been working with adult facilitators of those groups to organize logistics. In the conversations, we're talking to young people about their personal experience in sex ed, their perceptions of sex ed throughout Maryland and in the wider community, and their recommendations for sex ed policy and program changes. Participants are given a $50 gift card to thank them for their time. So if you all are part of or know of some existing youth groups who may be interested, please do let us know. We invite you to share flyers with your network. And in the chat, I have the name of my colleague, Pega, and Pega's email address to link us to folks. Okay, so that was a lot and it was kind of quick. What questions do you all have for me?
I just had a quick question. And this, I don't know, like how. So, have you all, I guess, had a discussion about like, youth groups at like faith-based organizations like churches and stuff like that? And if you would approach those type of youth groups, or are those kind of off limit?
Yeah, we're open to that. So far, most of the groups we've been talking to are related, like do direct work related to sexual reproductive health. But we'd be open to speaking with any kind of group that has interest in talking to us about sex ed, in school-based sex ed in Maryland. And Sylvia, I think we shared the flyer with the meeting organizers. Taylor, are you able to, or did you receive the flyer to share out with the meeting materials?
Yes.
Okay.
Teams is not working with me at the moment and won't let me send any attachments to you all in real time, but just know that it is coming with the meeting minutes. I'll have both the English and Spanish translated flyers available for folks.
Okay, thank you.
Any other questions or reactions for Lizzie? All right. Well, thank you so much for joining, Lizzie, and being with us throughout the call. And I will certainly send out this information and keep us informed as this takes place and as you are continuing to recruit folks. I'm happy to support throughout the process.
Thank you all.
All right, and next, wanted to lift up our friends over at the Prince George's County Department of Parks and Recreation. Are having a few exciting events going on this weekend and honoring and celebrating Black History Month. And so taking place this Saturday is a Headshots for Success event where folks can come and get a free professional headshot. And then there's also an afternoon aviators celebration for Black History Month also taking place this Saturday. And I know they have a few events going on through the rest of the month and then into March as well. So I will include the link to their calendar in the meeting notes as well for folks to take a look at. And I hope everyone can go and get a very beautiful professional headshot. And next, from our friends over at the American Diabetes Association, they are sharing a free film screening of a film called Impossible. It is based off of a true story here about an individual who was struggling with chronic illnesses and overcoming those and being able to live a healthier lifestyle in this with the support of the American Diabetes Association, the American Heart Association, and the American Cancer Society. So this is a free screening taking place on Wednesday, March 5th, there in DC at the Miracle Theater. So I will be sure to share this information with you all. You can scan this QR code and feel free to share it with your networks as well. And then we have the event that Mr. Taylor was talking about earlier, the partnership for a Healthier Prince George's County conference taking place on Saturday, April 5th. So I think he extended an invite to you all, and please do share this event with your networks to have as many representatives from Prince George's County there possible to, again, continue this discussion and be able to strengthen our partnerships and be able to learn from one another what we all do and where we all fit into this health landscape. So that will be taking place at the Prince George's Community College. Mr. Taylor, anything else you wanted to uplift about this event?
I think you said it at the moment, but again, it's, I've sent invite to all the municipalities because I would truly want the conference to be representative of Prince George's County, and having a voice or a seat at the table means a lot. Having been a person that's been out in the community, talk with residents, Latinos who I exchange information or communicated with by way of phones, using your phone. So there's way adaptive phone service to communicate. So we were communicating from English to Spanish using our cell phones. you know, because what they needed was access to fresh food, insurance, utility bills, and things of that nature. So where there's a will, there's a way. And so we want to have the community representative of the all municipalities. And so hopefully everybody will show up, healthy breakfast and stuff like that, and going to have a good time. And the idea is we just don't want to talk to each other. We want to walk away with strategies that we can implement. You know, you hear the top-down approach, but then we want to walk away with solutions that we can walk out of the conference and put to use. Okay? So enough said. I put my contact information and it's on the flyer as well as the in the chat. So feel free to contact me. Thank you.
Thanks, Mr. Taylor. And you have a request here for the registration link. Can you put that in the chat as well?
Let's see. Now I gotta go. Let's see, registration link. Let me hold on for 1 second.
Okay.
Let's see.
And while you're working on that, I'm going to move us to our next community announcement. So coming from the Maryland Department of Service and Civic Innovation, I got this email this morning that their service year option member program is available. It is open beginning in September 2025. So the early deadline for applications is taking place on March 1st. So if you know any recent Maryland high school grads or any folks who are graduating this year, feel free to send them this opportunity it's the application link there at the bottom is servemaryland.gov, an opportunity for a paid 9-month service experience with wraparound supports to ensure success. So I will be sure to send out this information in the meeting notes as well. All right. And any other community announcements or events taking place that anyone wants to mention?
Okay, I think I found it right here. Okay. Then go back to the chat.
Thank you for working on that, Mr. Taylor.
Okay.
Any announcements anyone wants to share before we hop off for the day? And there's the registration link for the April 5th event. And sorry, Rodrigo, I think I cut you off there. Anything?
No,
anyone
I
wants to add?
wasn't gonna say anything.
Okay, gotcha. All righty. Well, thank you everyone for your participation today. Upcoming meetings, we have our Prince George's Health Action Coalition. So our coalition at large is having our virtual quarterly meeting on Tuesday, March 11th in the afternoon, in the evening time from 6 to 7:30 p.m. And then we will reconvene as a Health Equity Workgroup on Thursday, March 20th. But be on the lookout for the meeting notes with all these community announcements and all of the flyers. And of course, please let me know if we can support you in any way, shape, or form in the meantime. But continue to take good care of yourselves, everyone. And I hope you all have a wonderful evening.
Thank you.
Thank you, everyone.
Take care. All right. Take care.